All right, it's 12:05, so I think we can go ahead and get started. Thanks everybody for joining. Let's go ahead and get started. Just a reminder, please, if you haven't already done so, go ahead and just rename yourself. So that's going to be your first and last name and your organization in Zoom. That way we can help keep track of attendance. And then we'll just go ahead and move on to housekeeping announcements and initial disclosures. So Project Echo and Reach collect registration, participation, and chat comments, and this data can be used for reports, maps, communication, surveys, quality assurance evaluation, and to start new initiatives. All individual data is going to be kept confidential. For educational purposes, we'll record the session and it's going to be available on our website for all participants to view afterwards and to share. By participating in this session, you are consenting to be recorded, and we definitely value all participation. So please feel free to speak up if you have any questions or comments throughout the session. And if you have any questions or concerns, please feel free to reach out to our other reach coordinator, Maggie. Her email is there below, maggie.palapoli@lcmchealth.org. So then moving on, so LMHPCO is accredited as a provider of nursing continual professional development. We ask that you arrive no more than 5 minutes after the start of the session and stay until the end. Participation is always appreciated. Be sure to complete the evaluations and to keep track of how many sessions you attended. And then we are able to provide CEU credits to those who are interested just by completing the email survey that's sent out after the session to get credit. So you'll receive that email about a week after. Just some basic Zoom etiquette. So please be sure to mute your microphone when you're not speaking. And remember to unmute before you want to start speaking. Speak closely and clearly to your microphone. Keep your camera on if possible. We love to see everybody's faces if possible. And if you have any IT issues, feel free to just drop it in the chat. We'll be monitoring that. And again, just a reminder, be sure to have correct naming on your screen. So your first and last name and your organization. That helps us send the surveys out to y'all afterwards for the credits. And then raise your hand if you'd like to speak, and please be sure to use the chat if you have any comments or questions as well. And I just want to put a reminder in that for December, our meeting is going to be on December 14th. That's the second Thursday of the month instead of the third Thursday of the month, to help coincide better with the busy holiday schedule. And that'll be included in the reminder emails that go out to y'all as well. So just some basic ground rules. This is a safe space. Everyone's thoughts and questions and concerns are all valid and valuable. Take space to make space, and what's said here stays here. So we ask that to protect the privacy of all participants, please keep everything discussed during the session confidential. And if you're sharing any real life examples from your work, only share de-identified information. And with that, I will turn it over to our facilitator, Stevia, to get started with the agenda.
Awesome. So welcome, everyone. Today on our agenda, we are going to go over our welcome and introductions as we always do. We'll review our objectives, have our didactic presentation, have a great case discussion, and then wrap up. This is a fairly long presentation, so we may not have time for mindfulness at the end, but if we get done a little early, we will definitely try to include it. All right, so for our welcome and introductions, for new members, I'd like to officially welcome you to the REACH Initiative. We're so excited that you guys are here. For returning members, we're so happy to see you again this month on our 11th month of doing this. For those of you who have not met me yet, I'm Stevia Davis, and I am the palliative care nurse practitioner at Children's of New Orleans. And I have the privilege of leading the REACH Initiative with Dr. Autry, and I'm your facilitator for this month's session. So to start, we're going to take a minute to introduce ourselves so we can get to know each other and continue to build that community. And we will go with verbal intros today since we're a smaller group. And I'll go ahead and start with the top name on my list, which is our Project Echo REACH host, Masood.
Hey everybody, my name is Masood Rezvani. I work at Children's New Orleans with Stevia and Dr. Autry, supporting the palliative care team, and I help serve as a coordinator for Project Reach. So lovely to see everyone.
Wonderful. Thank you, Masood. Next on my list, I have Dr. Autry.
Hi, everyone. I'm Ashley Autry. I am the palliative care physician here at Children's Hospital New Orleans, and I help run our Gulf States Reach, and I'll be presenting today. Nice to see everyone. Thanks for jumping on.
Wonderful. Next, I have Brianna, and I know it's just Brianna labeled, but I'll let you two introduce yourselves.
Hi, I'm Brianna. I'm actually the social worker on the palliative care team over at Children's.
Oh, hi, I'm Tracy. I'm the hospital medicine fellow, and I'm currently, I said Charlene, following the palliative care team this month.
Wonderful. Thank you. Next, we have Cindy Frazier.
Hi, Cindy Frazier. I am new with Allegiance Healthcare, not new to the hospice space. I've been in Louisiana and Mississippi for the last 21 years and am a board member with LMHPCO and am the most recent president with LMHPCO. So thank you guys so much for doing this.
Awesome. So happy to have you here. Next, we have Judy Zerang.
Hello, I'm Susan. I'm a nurse at Children's Hospital.
Judy, your volume was a little cut out a little bit. So I'll just, since I do know you, Judy is a nurse coordinator with the urology team at Children's Hospital New Orleans. Next, we have Laura Mooney.
Hi, yes, I'm Laura Mooney. I am the Regional Director of Quality Outcomes for Compassus.
Wonderful. Thank you, Laura. And then we have Megan Haley. Okay. It looks like Megan's a nurse at Women's. Oh, is she? Okay. And you can always chat it in the box if that's easier, if volume and all that stuff is not working. We understand technology glitches. After Megan, we have, is it Pengolio? I apologize for the pronunciation.
Sorry, it's Pauline Angolio. I'm a registered nurse with the hospice of Baton Rouge. I've been here 17 years. I was out in the field, and I'm currently the Director of Compliance, Education, and Quality. And I think this is the first one of these I've joined in person, live or whatever. I've seen a few after you put them on YouTube, and I just don't have much pediatric experience or knowledge to share with my team, and I don't think they were able to join today. So hope to gather something to share with them today.
Oh, wonderful. Well, thank you so much for joining us, Pauline. We're so happy that you're here and have been able to access our previously recorded sessions as well. Oh, and then I see we have Katie popped on. I don't know if you can unmute yourself.
Hi, I'm Katie Hilo. I am a nurse practitioner at the Children's Hospital in Baton Rouge, Our Lady of the Lake, and I split my time between palliative care and the St. Jude Affiliate Clinic.
Awesome. Welcome back, Katie. It's so great to see
Thank you.
New faces and those who have been with us throughout the year. So without further ado, we will so excited to welcome back the wonderful Dr. Ashley Autry, who is joining us from Children's New Orleans today, where she is our sole palliative care physician and interim medical director of our Pelican crew, the palliative care team. And our objectives for today that she's going to be touching on are discussing the importance of providing high quality end of life care to children, reviewing the most recent AAP guidelines, providing practical pearls for caring for children at end of life, and acknowledging that care for dying children is hard, very hard. So we will use the AAP guideline as framework for this discussion. And Dr. Autry, take it away.
Thanks, Divya. As always, so excited to see different people from all over the state. So we appreciate you guys joining and watching the recordings. Hopefully those will be used and y'all can share with other people in your organization who can't jump onto the live session, as you said. So we'll go ahead and get started. As Divya said, we're going to be leaning on the AAP guideline. So we'll kind of walk through different parts of it. But first, just acknowledging approximately 55,000 children die annually in the US. I think, thankfully, a lot of people don't realize that, and that's why everyone's so surprised to hear that there's hospice and palliative care for children. But unfortunately, that is the reality, and we all know too well how important and paramount it is to have high quality end of life care, not only to ensure that the child doesn't suffer, but also to mitigate the bereavement risks that the parents and siblings face as well. Actually, one of the stronger predictors of a tougher bereavement experience is, did you feel like your child experienced a difficult moment at the end of life? And so our goal is to try and prevent that. And sorry, not just at the end of life, but at the time of death. So we know that parents of children who die of cancer, who felt that way, they have worse bereavement outcomes. They have increased anxiety and depression. They miss more days of work. Their quality of life is poorer. And then interestingly, even higher mortality rates for these parents. So how can we try to help prevent this? So these are the components of quality end of life care that are mentioned in the AAP guideline. The final hours, days, and weeks in the life of a child or adolescent is obviously very stressful for patients, families, and us, the caregivers. And so we use this guideline to outline practical components of quality end of life care. And the information is meant to serve as kind of a primer for non-pediatric palliative care trained providers who are caring for dying children and their families. So these are the sections we're going to focus on today. And as mentioned before, this is meant to be an overview, but I am going to just kind of touch upon the first 5 sections that we're not going to dive into today. So pediatric palliative care engagement. We know that early integration is important, and not just getting in palliative care involved at the end of life, but giving us a chance to have a relationship and build rapport, build trust, so that we can really help guide these families as their clinical trajectory unfolds. Shared decision-making, our goal is to obviously provide medical expertise while also hearing and valuing families' goals and their values and hopes. And with the overall goal of reducing that burden on patients and families to make these decisions without any medical guidance. So we want to have shared decision-making. Advanced care planning. Parents report feeling more prepared for their child's final days if advanced care planning discussions have occurred, and they're less likely to have regrets. So really trying to have those conversations early when possible. And then code status documentation. Palliative care involvement has been shown to increase proper code status documentation. And actually, not only increase, but also have it occur earlier in the disease course. And we've found that to be true here in our hospital as well. And then location of death. Although data suggests that adults prefer to die at home, the pediatric data is less definitive. And so, assessing that, and we always normalize, we tell families, sometimes parents hope to have their child's final moments at home where they're most comfortable, and that's the most familiar to them, and others can't imagine having those memories at home. What feels right to you? There's no right answer, and every family is different. So not making assumptions that they always want to be at home. So now for the sections that we're gonna go into: plans for life-sustaining medical treatment, anticipatory guidance around end of life, symptom management, and again, overview, not necessarily like going into all the different medicines and indications, but we do have all those individual sessions on our REACH page. Bereavement care, and then team support for the healthcare team or the hospice care team. Okay, so plans for life-sustaining medical treatments. So there are so many choices that people are faced with, and so many forms of what we call life-sustaining therapies that could be offered. Mechanical ventilation, CPR, vasopressors, ECMO, dialysis, and then medically provided nutrition and hydration. And it's always important to think about how we are discussing these things and the language that we're using, and trying to avoid the words stopping or withholding care, and always using the language of life-sustaining medical treatment. Or if you're saying, sometimes I'll catch myself if I go to say, we're withdrawing, and I'll say life-sustaining medical treatment, or name the thing that you're withdrawing, ventilator, ECMO, whatever that may be. Another way is redirecting care to focus on comfort, but always trying to avoid the words withdrawing care, withdrawing support, without defining what that means. And then to talk more about stopping versus withholding. So in the eyes of the AAP, stopping and removing and withholding are all ethically equivalent. It may not feel that way morally, but legally and ethically, those things are the same. And even the AAP policy regarding, it was put together by the subcommittee of bioethics. The AAP policy on stopping or withholding life-sustaining medical treatment actually went so far as to combining those two words and just saying foregoing, to try to avoid this feeling of, oh, we're stopping something we're already giving. And then, so foregoing is, we know, is ethically supportable when the burden of treatment outweighs the benefits to the child. And we have to start to think about, are we doing this to the child or for the child? And then obviously the star next to artificial hydration and nutrition, I feel like a lot of healthcare providers and families, that one just hits a little different, because we're so trained to feel that feeding is a cornerstone of life and parenting, and that is nurturing. But we do know, thankfully, there has been some data and a study with parents who did opt to forego artificial nutrition and hydration, found that these parents were satisfied with their decision, and they greatly benefited from reassurance from clinicians that the patient was dying of their disease and not from a lack of nutrition, and that it's the disease that's causing them to not be able to tolerate nutrition any longer, or be able to take in nutrition. And so that's something that we have to continue to be very careful about how we communicate that with families, and using the language of protecting them from something that we worry is more harmful than helpful. And another thing is when we are communicating about our redirection of care or withholding or stopping life-sustaining medical treatments, we want to focus on the things that we're going to do as well. So other ways to nurture and nourish a patient, whether it's via touch, massage, music, and just being there, a loving presence and a familiar voice to these kiddos as well. And also always remembering that, of course, if they're stopping artificial hydration or nutrition, doesn't stop us or prevent us from offering any kind of oral care or feeds for pleasure. And then in pediatrics, another kind of difference from the adult world is that the patient's primary team often initiates these conversations, and hopefully they're being more proactive than reactive, and are able to have these conversations in a lower stress moment or environment. So we always first ensure communication with the primary team to know where the family is with these conversations. And I know when we do referrals to local hospices, we always try and fill them in on all the conversations that we've had with families so that they can pick up where we left off, or, we can kind of have an idea of what the family's goals are if something were to happen or things were changing at home. So unfortunately, there are still instances, obviously, where you may have to start these conversations at first in the home setting or not with the primary team. And so different ways to start that is just to start slow. And again, ideally in a time of stability so that there's not high stress emotions going on. And then setting yourself up to be able to plant seeds and then follow up in the future and give them time to think about it would be ideal. So some practical pearls. Again, we kind of touched on these a little bit. And I think some feel that having these conversations isn't our place, but of course it really is. And parents lean on us for our medical expertise in addition to their own values and goals when making these decisions. So we're always going to be talking with them and ensuring and reminding them that we're here to support them and care for them no matter what. So things to avoid. I think avoiding like listing off a menu of things. I think we try to assess goals and then make recommendations based on that. So oftentimes the phrases I usually use, or I may start in that kind of conversation is, I know how much you've shared your hope for so-and-so to be uncomfortable when we worry that time is short. And because of that, I really feel strongly that I need to share what I'm thinking and what I'm worried about with you. And then I may say, I recommend that if so-and-so's heart were to stop, or if he were to begin struggling more to breathe, that we would protect him from things that we worry could be harmful, such as chest compressions or shock, and instead intensively focus on his comfort and try to prevent him from experiencing any kind of distress or pain or shortness of breath or things like that. And of course, if I felt those things were helpful, we would do them. But I worry that if he were to stop breathing, it's likely because of his cancer, and we can't fix that. I wish that we could. So I think circling it back to why is the heart stopping? Why are we needing a breathing tube? Or why are we needing these things? And if it's something that we can't fix, and the family has already made it clear that they would want comfort in the end, circling the conversation back to all of those things. And then ending with a phrase, I wish statement that helps us to align with their goals. I wish that could be helpful. But it also gives the message that I medically don't think it will be. So that's just a more gentle way to try and give a medical recommendation and some guidance, as opposed to some of these things on the right. What do you want us to do? Do you want us to intubate? Do you want us to do chest compressions? Should we defibrillate? Those are all medical things. How will they know if that will be helpful for their child? And I think sometimes parents, they'll say, do everything. And when you ask them, can you tell me more about that? Can you tell me more about that? What does everything mean? They'll say everything that could help them. And so then you kind of go into that conversation again about what is medically helpful and what can fix things, what's reversible, and what are our thoughts about that. Okay, I think we covered everything else on this slide. This I threw in here this is an awesome Nathan Gray. He's an adult palliative care doctor. And he makes all of these really neat comics about different things in palliative care. And so these are some of the approaches we hope to avoid. So you'll see all or none on the top left. If your heart stops, do you want us to do everything or nothing? Because who's going to say nothing, right? And then the horror approach, unfortunately, I feel like I have seen that before, we don't always have to get into all of the details and how painful it is. We can just give a recommendation, and hopefully we've built trust with the family that that'll be heard. And then the menu is what I mentioned before. How many shots would you like with that? Do you want a breathing tube? Do you want how many doses of epi? You know, not getting lost in the details, because that's all medical decisions. Okay. So some practical pearls, and I kind of gave an example on the last slide as well. But I think the main thing here, knowing what I know about your goals, I would recommend, as his disease continues to worsen, it is likely that his heart will stop or his lungs will stop. If this happens, I recommend that he receive maximum comfort measures. Again, you're giving them some anticipatory guidance, but also giving a recommendation and telling them what we are going to do and how we can help them and how we will care for him. Another important piece, especially if parents are foregoing any life-sustaining treatment, is to affirm their love for their child and praise them and normalize that many parents feel the same way you do and worry that that could be painful. I can't imagine how hard and loving it is to make these decisions. And again, always using words that help families focus on promoting comfort and foregoing treatments, but in the context of I like protecting them. So like not using the language like, oh, we won't do this, but instead we're going to protect them from that, as we worry it could be more harmful than helpful. I think that just is such a good way to reiterate to parents that they're not withholding something that their child needs or would help their child. Because I feel like that's often the I don't know how to word it, but like the trap that parents fall into, feeling that way, unfortunately, and feeling like bad parents. Okay, I want to kind of pause there. Any questions or thoughts or experiences that you guys have had with or witnessed with some of these conversations?
We do have a comment. Dr. Autry, Katie said that she loves the term protecting and she hadn't thought of that before.
Oh yeah. Thanks, Katie, for sharing that. Yeah, I probably use that every single time that we're not doing anything. Even protecting them from chemotherapy or medicines that we worry aren't accomplishing the goals that we set out for. It's such good language.
I also wanted to ask, sorry, I'm eating lunch, or I would have my video on. I've heard a lot of people say, that they can't tolerate it. Like this isn't an option because they can't tolerate it anymore. And it kind of recently just kind of stopped me and made me think, like, is that a good term to use? Because in a way I saw it as they're saying this in front of this teenage boy that his body can't tolerate it. Is he maybe taking that to mean he's not strong enough, like mentally, emotionally, all those things. And I just wanted to know if you had any recommendations for, not recommending to go forward with something, but without maybe saying, I don't think he'll tolerate it.
That's a good point. I hadn't heard the worry around that particular phrase. I have heard it around, you've, like, for example, a different situation, the child failed extubation or
Right.
they failed something. But I do think with that language, you could just follow it up with, but making it more about the disease, like,
Right.
unfortunately, your body is just fighting this disease so hard that now it's not able to tolerate the medicine. Like the body is not, like, as opposed
Right.
to he is not.
Distinguishing it. Yeah.
And I think that conversation usually, I would think, is the medicine, like, what's the goal of the medicine? And is it accomplishing our goal of not? And if it's not accomplishing the goal, then I think that should be a different conversation. Or if it's a medicine that is accomplishing the goal, but unfortunately the side effects are just too strong, then explaining it a little bit more fully so that, like you said, they don't feel like it's their fault or they're a failure.
Right. Okay, thanks. That helps.
Okay. Okay, we'll go into anticipatory guidance. So obviously, there are a lot of things that sometimes we need to cover. And again, the patient's primary team is likely to partner with you and assist you with many of these conversations, such as legacy building or even supporting the siblings. So legacy building and sibling support, we're thankfully able to lean a lot on our child life specialists here in the hospital. And I understand some hospices also have child life specialists available to them. But they are always great tools. But also leaning on if you have a bereavement coordinator, or just having that conversation with family about what's going on and seeing how you can best support them as well. Physical signs and symptoms of dying. Obviously assessing symptoms and trying to prepare them for what they might see, or what might worsen over time. And I think the main things are often changes in breathing, changes in color, skin color, vital signs, alertness. And then, as we mentioned before, I think a big one to kind of prepare families for is children not being able to tolerate feeds any longer, whether they were eating by mouth or they do have artificial nutrition. Letting them know, I try to, whenever we do a hospice referral, at least plant a seed that, there may come a time that their body's not able to tolerate this anymore. I guess there you go, Katie, like focusing on the body. As it shuts down, it may cause more discomfort. And so that's a conversation we can have if that happens. So kind of planting that seed that this may not be helpful until the end, or this may not be recommended to be continued until the end. Symptom management, funeral planning, and autopsy. Another thing, for physical signs and symptoms of the dying process, I think it's really important. Clinicians often, not always, worry about uncertainty and hesitate to give a time frame. But I think that can be so hard for families. So I always encourage our nurses and our doctors to talk with families if they're asking about this, and even if they're not. And giving them an idea. So I lean more on guideposts such as days to minutes, or minutes to days, or days to weeks, weeks to months, months to years. Usually a physician can commit to one of those guides, and also always giving a caveat of it's so difficult to predict how long the dying process can take, and every child and every child's body is different. But I worry that it may only be days to weeks. I may be wrong, but I just want to be honest with you about what I'm thinking, so that they can, plan accordingly. They may take a trip tomorrow instead of waiting 2 to 3 weeks, if that makes sense. So just giving them the chance to do the things that they want to do with that information. Okay, I mentioned this a little bit on the last slide, engaging your interdisciplinary team. So child life, bereavement, spiritual care providers, music therapists, if you're lucky to have one. We do have one here at Children's Hospital, and we lean on them a lot for heartbeat recordings or heartbeat songs. Social workers, physicians, our APPs, and our bedside nurses, of course. And then again, some of the different options for memory making. I mentioned the heartbeat recordings, and sometimes, but all of these things can mostly be done in the home, except for maybe the heartbeat recordings. But you can always reach out to the hospital. Even sometimes if they ever had an EKG, sometimes they could get a copy of that. And there's some really cool things that on Etsy that you can do with a printed heart rhythm strip and different art. So thankfully there's always options even outside of the hospital. But this is just a little list, locks of hair, fingerprint charms, and then if you get that handprint, footprint, thumbprint, again on Etsy, as long as you have that print that you can send to them, they can make all kinds of art or jewelry. It's pretty endless on what kind of things they can create with that memory, that little keepsake. Okay, so here are some other ways to start conversations about end of life. I think we always ask, what are you worried about? But sometimes parents don't always share and how much information is helpful at this time. These really open-ended questions, but sometimes parents don't always share those deep worries, or they're too scared to ask. So I really like this third bullet. Would it be okay to talk about what may happen over the next couple of days? Or I like to kind of always give examples of other parents. So for example, many parents really appreciate knowing what to expect over the next few days. How do you feel about that? Would that be helpful? So, always giving an example of other parents and normalizing that. And then you could also use an I wonder phrase. So you heard me talk about I wish. So I wish, I worry, and I wonder. And we talked about I worry as well. I wish, I wonder, and I worry are really good tools to have in communicating with families. And I wonder if we could talk about, or I wonder if, if I say, a lot of parents find it to be helpful to know what to expect. I wonder if that would be helpful for you. It's kind of just a gentle way of making a recommendation or exploring with them something different. So these are actually some examples and phrases for particular signs or symptoms. So I mentioned some of the big ones being decreased appetite, decreased alertness, the changes in breathing, the skin changes. I think another big one I didn't mention before is the noisy breathing, or the audible secretions. And similar to this statement about that noise may sound uncomfortable to us, but it won't bother him or her. I often tell parents that that sound is actually telling me that his airway and all of his muscles are very relaxed, and that's not unexpected during this dying process, and it doesn't cause him any discomfort, even though it may sound worrisome. So just kind of telling them that's literally what's making that sound is everything being really relaxed, and then always leaning on the facial expressions of the child, and reassuring parents based off that, that they aren't experiencing any distress or pain. And again, these recording will be up, and we'll also send the link to the article that has all of these things, like for print, that you can print as well. So I think this is an important piece that we often forget about, is engaging the child and communicating with the child as well. There's a helpful article, it's pretty old now, it's from 2005, that provides a framework on how to include children in this kind of discussions. It is based on oncology, but obviously a lot of the principles are really generalizable to other illnesses as well. But these 6 E's is helpful. And it focuses on including the child from the beginning, because it can be hard to do so just at the end of life, especially with a lot, maybe some symptom burden or decreased alertness or things like that. So establishing that open communication from the beginning, always engaging the child, exploring what they're thinking, what they know, and what they want to know. I think that's an important piece too. Explaining information in a developmentally appropriate way. And again, leaning on our IDT and our child life specialists to help us do that, or partner with us to do that. And then offering that empathetic communication with them as well. And always encouraging them with your reassurance and reminding them that they can always come to you, and building that trusting relationship with not just the parents, but the child as well. And I think another thing that I like is tell me what your body's telling you. I think that's a really gentle way an open way to see what kids are thinking. And then this article as well, we'll send out in the resources. So these are some tough questions that Parents can sometimes ask, how can I possibly stop feeding my child? What am I supposed to do? I can't watch my child starve. How will I know if my child is suffering, and can my child hear me? And I think the first two we touched upon. Again, I think I would respond. Sometimes these questions are coming from an emotional place and also thinking about their anticipatory grief. And so just at first, just responding with empathy and like, God, I can't even imagine how hard this must be. Like you're being an amazing mom. And I want you to know that I hear you, and I'm going to try and do everything I can to make sure that so-and-so is comfortable. And then going into why or what the worry is about the feeds, and that knowing that mom has shared how much she wants him to be at peace and comfortable, explaining those worries again. So again, aligning with their hopes of comfort and circling back to what their goals are for the child, and then giving that medical information with I worry statements, and also focusing on what we are going to do, how we are going to nurture their child. If they want some like ice cream or something like that, of course, giving that. And sometimes, I haven't done it in a while, but sometimes it's also helpful when talking about the body shutting down, similar to when we have the flu or your body's fighting off illness or dealing with illness, there isn't a feeling of hunger or thirst. And that the child is showing us that. Going back to how will I know if my child is suffering? Again, directing mom to look at facial expressions and look at signs that the child's comfortable, and pointing those things out as well. And then, can my child hear me? I think we always lean on telling parents that hearing is one of the last senses to go as the brain does slowly shut down, and also reassuring them that their presence and connection can always be sensed, and reassuring them that is important, and that's felt by the child. Okay. I'm going to stop there for a quick minute as well and see if there's any other things to share, or if anyone else has any tips or phrases that they've used in the past. Okay, I'm going to go on, but you can always type something in the chat. Okay, so symptom management. This is a PDQuest study from 2015, and it aimed to describe the symptom distress of 104 children ages 2 and up of advanced cancer. A lot of our data, as you can tell, is from the oncology population. But we know that these are generalizable concepts of end of life and the dying process. So this study, basically the take home was that pediatric patients experience a lot of distressing symptoms, and that unfortunately these symptom burden increases as the child progresses towards end of life. So this is just an overview of the progressing disease, the decline, and then the increasing symptom burden as the child nears the end of life. And then bereaved parents actually report feeling like their child suffered a lot or a great deal from at least one symptom during the last month of their life, and that the treatment attempted was often unsuccessful. And so this is a really important priority for us as we care for kids at the end of life. And then this statement, parents who felt that their child's final day was overdue often referred to their child's overt suffering and their child's survival for longer than the parent thought was humanly possible. And actually, other wording that the authors of this paper had considered was parents who wished that their child had already died. And that's just how raw the emotions was when they were writing this, and from the parents, and how important it is that we try and limit their physical suffering and their symptoms as much as possible. And speaking to that, more than 10% of bereaved parents considered hastening their child's death, more likely if the child was in pain. And then we talked about the difficult moment. If parents feel like they had pain or difficult moment at the time of death, that the parents had worse bereavement outcomes as well, and increase. And that was a strong predictor for increased mortality of the parents. And so we want to aggressively manage these symptoms as much as possible with our goal of comfort. The key medications, obviously, I'm sure many of you know, opioids and benzos, trying to treat dyspnea, anxiety, pain, agitation. There's no maximum dose, and we titrate to effect. And use of these medications at the end of life does not hasten death. And there's literature that tells us that when you use appropriate dosing, that this really isn't a concern and it doesn't hasten death. If anything, it could prolong life with better symptom control. But of course, we always think about the principle of double effect as well, and know that our appropriate intent and appropriate dose is what justifies the use of these medications. And that if there is a side effect of respiratory depression and that happens, we know that our intent was comfort, and allowing that child a death without suffering. And then some other medications, anticholinergics to help us with secretions, antipsychotics to help with delirium, which is important to remember that these patients are sometimes have brain metastasis or brain pathology. They're less alert just from the dying process. A lot of times the opioids and the benzos, and so they're definitely at high risk of delirium as well. And then antiemetics. And when we think about anesthetics, that's more if we're having refractory suffering and thinking about what we call palliative sedation. That would oftentimes is in an inpatient setting. And I think thinking of symptoms at the end of life as a palliative care emergency. And so just really focusing on that and educating parents. I think that sometimes they get used to having some of these symptoms throughout their medical journey, but at the end of life, this is a palliative care emergency. This is a symptom, a comfort emergency, and we want to aggressively address them. And so that may require rapid dose titration and dose escalation, and frequently if needed. And we always want to be the calmest person in the room, especially in those kind of palliative care comfort emergencies, and focus on what we're going to do for the child for their comfort. And always checking in frequently with the family and other members of the IDT. So you've probably been familiar, we've shared this almost every talk, I think, is the Dana-Farber Blue Book. And this is a pediatric palliative care pain and symptom management resource. I probably reference it. It's every other day, but it has lists of medications for all different symptoms, as well as opioid side effects, which I find really helpful. It's got the doses, the routes. It's super, super informative. And you can pull, if you Google palliative care Blue Book, Dana-Farber Blue Book, it comes right up. There is actually, I think there is an adult version as well. Obviously, I don't look at that often, but that could be helpful for y'all too. And we'll send that out and the with the resources. And then one other quick thing I did want to make sure I mentioned that we're always educating our staff on, especially at end of life, is if the patient's experiencing discomfort and we're going up on a medicine, always going up by at least 25–30%. A change of 5–10%, that's not really going to make a difference. If you think about it, when you're doing medications, you round up sometimes, and that's not like going to increase comfort. So if a patient is having discomfort despite the medicine and you feel like we need to go up, going up on at least 25–30% at the bare minimum. And then honestly, if depending on their severity of their discomfort, if it's moderate to severe, even thinking about 50–100% of an increase. There may be times that you double the medicine if they're in extreme pain and it's not helping. Okay, and then so I think I've heard some of you guys having comfort kits. How many of you guys use comfort kits, whether with your adult population or with your pediatric? in the home. Yeah. So Usually there's comfort kit when oftentimes when patients get admitted to hospice, adult hospice for sure, when the goal is always comfort. I think in the pediatric world, it's not always used just because sometimes patients aren't nearing the end of life like in the adult world. But I think it is something good to have at hand if needed. So this is just an example of a pediatric comfort kit. And it can look a little different than an adult version. Okay. So I'm going to keep going, but if there's any, oh, I see. Is there anything in the chat? No. Okay, good. No questions. But feel free to put any questions if needed in the chat. And then, so bereavement care, we're going to touch on this, but thankfully our next and final session is all on grief and bereavement. But obviously we know that this loss is incredibly devastating and life altering. And we know that these parents are at risk of facing some really tough times and increased mortality and everything we talked about before. And just the death of a child in general puts them at risk of complicated or prolonged bereavement. And so high quality bereavement care should really be our standard. And thankfully that is provided for a year through hospice support. And then also giving them the resources of support groups, parent-to-parent mentorship or other bereaved parent support, grief counseling, mental health resources, and then those check-ins from the hospice bereavement specialist. And then families, we know that they really value, and not only do they value, but they expect, that support from their child's healthcare team as well. So opportunities to send condolence cards and provide that support. And when thinking about writing condolences, you want to make sure that you give a statement of genuine sympathy. You can share a story of the child or a memory. One time I did my training at St. Jude, and we have a really robust bereaved parent program. And a bereaved parent once told me that, when their child dies, there's no chance for new memories or to be made. But when someone shares a story or a memory of that child that they weren't aware of, it's like creating a new memory, even though their child is no longer with them. And I felt like that was so meaningful. And it always helps me to try and make sure that if I'm writing a condolence card or expressing sympathy, I try, even if it's the smallest thing, try to say something about the child or a memory. And then reminding the bereaved parent of their strengths. And again, using that opportunity for a statement of praise. You are such a loving mother. And even referencing some of the decisions they made and how inspiring it was to see them protect their child. And then if talking with families, give them a chance to share a story. Bereaved parents had also shared at St. Jude that, when they're in their daily life, a lot of times people avoid it or they don't mention the child that's no longer there. And so when they interact with healthcare staff or people who knew their child, it's sometimes the only chance they get to talk about that child. And so giving them that chance or listening to those stories can mean so much. And then just an example, our team, we send condolence cards within a couple weeks of the death, at least within the first month. And then we send one on the child's first birthday after they've passed, and then on the anniversary of their death. And I know another program that I trained at, they also send them on Mother's Day and Father's Day. So it just depends on how much your staff can handle. And obviously that requires time to send all those cards out, but those are some of the tough times for families. And then finally, team support and recognizing, that this impacts the whole care team. And so the AAP put together a resilience curriculum for pediatric providers, and that link will also be provided and sent out in the resources as well. And on our team, we do what we call a pause, and I encourage y'all to do that. It's a short, I can read it really quick. Let us take a moment to acknowledge our experiences in caring for the blank family. So-and-so was loved enormously in this world by, and you list their parents' names or their siblings. In our own way and in silence, let us take a moment to honor so-and-so. So that's just a small, we do that every morning after the death of a patient, just a small way to acknowledge that. And then another idea is debriefing, after a patient dies and your hospice team has cared for them for weeks to months. And especially if it was a particularly tough case, allotting 15, 30 minutes or more if needed, to just kind of all meet together and debrief and talk about why it was hard or what that patient taught us or different things like that. Okay, so that brings us to our case discussion. You're gonna go, Stevia?
Yeah, I can pop in. So just a reminder that we can submit any case discussions that y'all have from out in the field on our website. And it does not have to be of any of the subjects that we've already talked about or what the upcoming subject is. We welcome all different case discussions. So our first case discussion is about Will. He is a 12-year-old boy with a hospice diagnosis of metastatic bone cancer. He is no longer receiving cancer-directed therapy and has a DNR in place. Will has been declining over the past 2 weeks, and he is now remaining in bed the entire day and not eating or drinking as much. He's had increasing pain to his right lower extremity, and you've been making frequent home visits and up-titrating his pain regimen with your hospice physician. You most recently started him on methadone 5 milligrams twice daily with morphine 10 milligrams Q4 as needed at your visit 4 days ago. His parents call you this morning to come and assess Will due to his pain. At the visit, Will is crying in his bed and having a hard time communicating due to his pain. His dad tells you that Will was using 5 to 6 doses of the PRN morphine per day in addition to the methadone. He also says that Will has started complaining of difficulty breathing. Will wants to remain at home and not to return to the hospital. So thinking through this scenario, has anyone had any experience with cases like this? I will ask our presenter Dr. Autry, do you have any thoughts on how you would proceed in a case like this?
Yeah, I wonder, what do you guys think's going on, or what would be any other questions that you'd have or thoughts that you have about what's going on with Will or what we should do?
I would work to assess like his anxiety, his, kind of what he's thinking. If Will has specific questions, because I'm sure he does with his pain increasing, what that means. So really making sure, I think that you're talking to Will as much as he's able to communicate, but just trying to figure out if there's something else we're maybe not addressing besides just the physical pain.
Yeah, I think about that question. I think what you're speaking to, obviously addressing symptoms, but also what is he thinking, and is there anxiety component as well, and just is he aware of what's going on with his body? And so I feel like this would be a good opportunity for that question about what do you feel like your body's telling you, or what do you feel like's going on in your body? And then symptom wise or symptom management, any next steps or thoughts that y'all have about his medications or what we should do? I think also naming, like Katie was kind of making sure that Will's aware of what's going on in his body, and naming, I'm looking at at the case, and he's declining not just today or acutely, but over the past 2 weeks, it's been a slow decline. And it sounds like he's had decreased alertness, decreased appetite, increasing pain, increasing shortness of breath, respiratory changes. And then his function is decreased. So obviously concerned with his metastatic cancer and lack of cancer-directed therapy that he is dying, and he's actively dying. And with his goal clearly being to be at home and to be comfortable and not return to the hospital, we want to address his symptoms and be aggressively and treat this as if he's crying in bed, that I would consider that severe uncontrolled pain or uncontrolled symptoms. And he's on a long-acting methadone with a short-acting morphine, but he's needing that 5 to 6 doses a day. So would definitely go up on his long-acting. And then even with all of that, he's still crying in bed. So I would go up on his methadone and his the long-acting and the short-acting. And as we mentioned before, I would go up probably, 50 to 100% since he's in such severe pain. Any other thoughts?
What?
I have a question. Can you hear me, Dr. Autry?
Yeah.
Okay. I have a question. So at what point, like given this case, I know like he's declining and I guess we're more so wanting to treat the symptoms, knowing that he's declining irregardless. But in what case, like let's say this patient was on Chippa and he's like made that decision, I want to go on hospice, want to go home, has this difficulty breathing, when do you weigh that benefit of, you know what, I know he has difficulty breathing, let's just give him the opioid, as opposed to, no, actually let's change his pain management to something else. I don't know, is it more so goals of care that will kind of weigh in the decision too?
Yeah, exactly. So this patient is at home and made it clear that they don't want to go to the hospital, and we know he's dying. So, and it has a DNR. So comfort's our only goal. And so we treat that difficulty breathing with opioids to try and alleviate that feeling of dyspnea. If he was in the hospital and hadn't made that decision yet, we would have some of those conversations to get to this place of, what are our goals? And we do know the literature tells us that, and I think it's 10% of families, no matter what communication, no matter what recommendations the doctors give, they want to do everything, even if the doctors feel that won't be helpful. And so you're still going to have those families who want to try the breathing. They want all the time possible, even if we worry they'll never come off of a breathing machine or that CPR won't help them. And so you are going to have those families. And so if that's the case and they're in the hospital, then trying to, again, have those conversations and think about comfort in addition to those things. Does that answer your question? And also, I think a thing that comes up often when we're having a patient who has all of these things, they have a DNR in place, we're focusing on comfort, and they're in the hospital, and sometimes at home too, I guess, is oxygen. And oxygen itself does not, when they do studies that show oxygen versus no oxygen does not provide comfort. It doesn't increase comfort when they measure that. What can increase comfort is the feeling of air blowing in the face. So when they put on a cannula with no oxygen versus a cannula with oxygen, it was the same, but it was that air and the no oxygen, it still helped in the same. Does that make sense? So it's not the oxygen that provides comfort. I've heard concerns from hospital staff. Why aren't we giving them oxygen? That's inhumane when they're uncomfortable with their breathing. And so I have to explain to them that doesn't been proven to help with comfort. And if anything, that can prolong the dying process for a family who just wants them to be as comfortable as possible and to protect them from more suffering. So sometimes oxygen can be a big conversation in and of itself. And what is the goal of the family? And is that going to accomplish the goal? So instead of oxygen, another thing you can think about for him is a bedside handheld fan, like to blow some air in their face. That can help too. And if you think about it, it's kind of like if you're car sick and you put your head out the window, I get car sick, and that air like can help that feeling of like shortness of breath or that sick feeling, if that makes sense. Okay. You want to go to the next slide? See, let's see.
I will say too, the oxygen, I found, it's really important to talk to families about that beforehand. We had a guy who was actively dying, and he was on not much oxygen, but he was on it. And we had talked to mom and dad about, being able to get closer to his face, and the cannula had previously bothered him. So like maybe he'd like that off. And while we were explaining it to the parents, we didn't necessarily make sure like everyone in the room knew that. So when we took the nasal cannula off and he happened to die shortly after, the grandmother gasps and she's like, they killed him. They took the oxygen off. So definitely like just being mindful of who's in the room and how much you're explaining it is just really important with the oxygen.
Yeah, that's helpful, Katie. And I think remembering that oxygen can help with, not always, obviously, but to an extent, if with desaturations. And so if the goal is more blended and a family still wanting more time, and like Katie said, at the expense of comfort, if a child, especially if they don't want the cannula, oxygen can help with desaturations, but not with comfort. So again, always thinking about that goal and how we alter our care based on the goal.
Awesome. Great discussion. So heading on into this, further into the case discussion, you call your hospice physician to discuss Will's clinical status. You give him a 20 milligram oral dose of morphine, which helps him settle, although he's still in a 5 out of 10 pain. You share your worries with Will and his parents that he may be progressing towards end of life and that you would like to start a morphine PCA to improve both his pain and difficulty breathing. Will and his parents agree. You call your hospice physician again to discuss starting a morphine PCA at 1 milligram per hour with a 1 milligram boost and continue the methadone at 5 milligrams twice a day. Once the PCA is started, Will continues to settle and is able to tell you he feels better.
Yeah, I think this brings up another thing we didn't talk about is the PCA. So the methadone, because it's so long acting, you only want to increase or make changes every 3 days. So because our assessment that Will is actively dying, it's appropriate to switch to a PCA, something we can change more quickly and more often than the methadone, because it takes so long for that change to take effect. So that's a really good thought that we didn't cover before. So instead of increasing the methadone, going ahead and adding a morphine PCA, keeping the methadone on, but the PCA we can increase and change as needed in the moment, as opposed to the methadone. And then what else is in here? Let's see. And then, yeah, it looks like notice we went from morphine 10 to morphine 20. So we went up 100%. And it's important, even though you're doing the PCA, it's helpful to give that big dose, that kind of like a bolus, to get things, take the edge off and get things under better control. As then you add on more long acting to an extent with that continuous infusion from the morphine. What else is on here? Any other thoughts? that we didn't already cover when we talked on the last slide? Okay. Let's go on.
Okay, so you return the next day and Will is boosted over 20 times in the past 12 hours that the PCA has been running. And just a reminder, the boost is 1 milligram. He is not crying in pain today, although he tells you the lowest his pain has gotten is a 4 out of 10. So how might we optimize his medication regimen even further?
What do y'all think? It sounds like moderately, 20 times is a lot though. So moderate to severe, even though he's not crying in pain, he's needing a lot. So definitely increasing again, as I similar to the first slide on his PCA bolus and continuous by 50 to 100%. And you still have that methadone in the background that you could always increase, but you just have to know that that'll take a couple of days to take effect. Any other thoughts before we go to the next slide?
I know when we're managing patients like this at the end of life, I'm always much more aggressive in going more like 100% increase, especially with like 20 times in 12 hours. That would be considered more unacceptable for end of life and focusing exclusively on comfort.
Yeah, that's a good point. And I think the other thing Katie kind of mentioned on the first slide, like that anxiety component. So obviously we're escalating our opioids, but we can also be thinking about other things going on. So benzodiazepines, and like we mentioned earlier, like delirium, just trying to think about those things besides pain that may be going on or could use other management, and then non-pharmacologic as well. So distraction, having friends come visit, normalizing this process, just thinking about all the other things that could be going on besides just his pain.
Yeah, can you hear me?
Yeah.
I was gonna suggest also I do a thing. I mean, this might not be the time to teach it. Hopefully we would have taught it earlier on, but visualization, guided visualization, every time they push that button, I teach them to picture it going into their veins, going into the parts that are hurting, just to give them an added something else to think about so that that medicine can work, and teaching them breathing techniques. Obviously, having the parents, family massage their hands and feet, like you were saying, the non-pharmacologic things. Not to say that you still don't that you still don't go up on the medicine, but the hope that as you go up on that medicine, it has a better effect and calming the patient, especially since it's end of life, and it gives the family something to do. Like even if it gives them that touch, and that, because sometimes they need permission, sometimes they need permission to touch them and talk to them and things.
I love that, especially like visual. I think it oftentimes it's so psychological, like prepping them, like this medicine's going to help you, like picture it working. I love that. And then just the calming and the distraction of the exercises, so many different ways that could be helpful. And then also addressing obviously anxiety component as well, and trying to calm. Thanks, Stacy.
Okay, so you doubled the morphine PCA to 2 milligrams per hour with a 2 milligram boost, and you increased his methadone to 7.5 BID. Over the next week, you see Will daily as he continues to decline and his symptom management needs escalate. He's now on 10 milligrams of methadone BID and a morphine PCA at 5 milligrams per hour with a 5 milligram boost. At your visit today, Will is sleeping and his parents tell you he hasn't woken up to take his methadone since yesterday. During your visit, he has frequent periods of moaning with facial grimace, and his parents are pressing the PCA button to give him a boost. So how can we continue to optimize his medication regimen?
What are y'all's thoughts?
At this point, do you check to see, is he like, is he having bowel movements? I mean, now he's on a lot of medicine, but he might not be eating. Is he pooing? Is there something else, some
Yeah.
other symptom that maybe we could address that might help? And then maybe adding something else. I mean, is it maybe not pain? Maybe now he's having anxiety or something. I don't know, something else.
Yeah, yeah, exactly. Similar to the last slide, like thinking what else could be going on. Whether it's anxiety, constipation, delirium, because he's still moaning and grimacing. So some, but thankfully he is sleeping, and that may just be and not able to take his methadone. Again, that's probably not unexpected with just his body shutting down as well, and just more signs of that active dying process. So yeah,
Would you
go ahead.
Would you consider going up on his basal? That way, kind of take it off the parents from having to push it. Recognizing that he is needing some, maybe not as much. But yeah, just kind of, I like to take as much off the parents at the end,
Yeah.
so they're not the ones having to make that decision and physically press the button.
Yeah, I think with him moaning and grimacing, it definitely, he's showing signs that he's still uncomfortable. So going up on the PCA, the basal, and the boost, and then even maybe converting the methadone over to the PCA, since he's not able to take any PO, and then thinking if he has any other PO medications, thinking about that as well.
Awesome. Okay. So you switch his methadone to IV and increase the dose to 15 milligrams twice a day. You also increase his morphine PCA to 7 milligrams per hour with a 7 milligram boost. Will appears more comfortable after you increase his PCA. The next morning, Will's parents call to say he is gasping for air and moaning. They are very tearful, asking what to do. You instruct them to press his PCA button and you head to their home. On the way, you call your hospice physician to discuss Will's clinical status and potential options for additional symptom management. So how can we continue to optimize his medication regimen?
Now, what do y'all think?
A little Ativan sublingually. I don't know.
Yeah, they still haven't mentioned benzos, so I definitely, yeah.
Because the goal is comfort, right? Is just comfort through.
Yes, he's at home and he has a DNR in place and he doesn't want to go back to the hospital.
Yeah.
I do think it is like, I probably would have just converted the methadone to the PCA because I mean, this regimen's getting pretty intense for at home. So I do think that's always worth a conversation if we're getting to a point where we really can't get him comfortable at home, having that conversation with the family, is it worth going into the hospital for one night to try and get things in a better place and then going back home? There are worse things than having to go into the hospital if it could improve comfort, because getting BID IV plus the PCA, that's just a lot of IV. So just like always having that in your mind if things are getting really uncontrollable. But again, we want to intensively escalate at home if possible. Any other thoughts besides adding a benzo? And again, thinking about delirium, like haloperidol or something like that, if we feel like that could be going on. But obviously the gasping for air tells us we want to go up on our opioids as well.
I still have patients that benefit from like a fan by
Yeah,
their
yeah.
face close to the bed. I know some people think that's too old school, but I think it helps. So
Yeah,
that's an
we
option.
keep them here, Katie, to give to
Yeah.
families at end of life in the hospital too.
Well, I think too, not even thinking about the medicine, just like really spending the time with parents to help them understand that, what's happening, why it's happening, and just really that anticipatory guidance throughout the process.
Yeah, like you're picking up on like the parents are tearful, not the patient was tearful and he's obviously showing signs of distress, but now the parents are tearful. And so I think it's great that you head to their home. So having that in-person presence and helping and support and walking them through the next steps together. Okay, we'll go on. We're getting close on time.
All right, so when you arrive to the house, Will's parents are visibly upset. His mother, Lauren, tearfully says, "I can't watch him suffer like this. Can't you just give him something to stop his suffering?" So how would you respond to mom when she asks you this question?
Has anyone had to deal with this before?
I would call y'all.
And in my experience, I've had, where parents, they maybe don't necessarily say it in those words, but will take the time to kind of understand better, what's the most distressing part of this that they're seeing, the tell me more types of things. And then sometimes I feel like it helps when we kind of review, everything we've done and kind of walk through again, like using anticipatory guidance within that and kind of what we've expected to see and what we're seeing. But really, I think just finding out what is most distressing to them, reinforce that they are doing a good job, that they're great parents and show them other ways that they can love him and be present with him. Sometimes is more helpful than, just addressing can you do something to make it stop?
Yeah. And I think, like you said, remembering just that this is kind of from such an emotional place, and you want to start by just with that, going back to that empathetic communication. And I can't imagine how difficult this is, and I want you to know that I'm going to be here until we get things under better control. And just that statement of praise and also reassurance that we're here to support them and we know that this is unacceptable and to get to a better place, knowing that our goals are comfort. And then I think, like you said, Katie, like, tell me more, like, can't you just give him something to stop his suffering? That doesn't necessarily mean mom is asking for us to hasten death. Like, some people may misunderstand the question, but like you said, tell me more, not making those jumping to conclusions, but tell me more. What do you feel like is causing him the most suffering? What should we focus most on? And really getting her take on what's going on. And like you said, going through what we're going to do or how we can best manage that. And then again, if parents are really at this point, like, would being in a hospital be better for symptom management, for their distress? Just having that in our minds too, if we're not able to get things under control. Okay, this is the last slide.
All right, so you share your worry with Will's family that he's actively dying and that you will do everything possible to make him comfortable and relieve his suffering. You tell them that you will remain in the home and to provide medications. You titrate his morphine PCA to 10 milligrams per hour with a 10 milligram boost and start a lorazepam infusion at 0.5 milligrams per hour. You also continue his methadone at 15 milligrams twice daily IV. You call in the chaplain and social work to provide additional psychosocial support to Will's parents and 2 siblings. Will achieves comfort on a morphine PCA 15 milligrams per hour with a 15 milligram boost and a lorazepam infusion at 1 milligram an hour. He dies peacefully surrounded by his family.
I think that's another thing we forgot is obviously I'm thinking medicine, but obviously with the parents being tearful and, addressing their spiritual suffering, their psychosocial suffering, maybe their worries about the siblings, just everything in addition to Will's physical suffering. And then they added the benzodiazepine to also treat anxiety. Any other thoughts before we end the case? And again, I think this would be a good time for the pause when he dies. And, you have your nurse who is managing all of this and called the physician when needed to go in person, and then the chaplain and the social worker. So all coming together to reflect on the care that they provided as a team. And these are some of the resources we talked about throughout the session. I think Stevia put some in the links and we'll send them out as well. That resource for talking with kids and then the resilience curriculum. You want to go ahead and wrap up, Stevia?
Yes, so thank you all so much for coming in this great discussion. This is a difficult case for symptom management, end of life, and it was a great discussion. So always come check out our lmhpco.org/reach website for the overview and the session recordings, and to submit your case discussion form. Please remember to complete your survey so that you can claim that CEU credit. You can email Maggie with any questions or concerns. And our next session will be Thursday, December 14th. And that's the second Thursday of the month instead of our usual third Thursday of the month. And the topic will be bereavement care with our very own Annie Vaden, social work on the Pelican crew from our hospital. So any last minute questions? I know we're a little over, so. Well, thank y'all so much for joining. So great to see y'all, and I hope that you will join us next month on December 14th. Have a great rest of your day.
Thank y'all so much.
Thanks.